Professor Selitsky, thank you very much for those very kind words. It's a real pleasure and honor for me to be here in this well-known, famous university and wonderful city. There are so many things that one can and should see, and on a single visit, one can only scratch the surface, so to speak. Today, I'm going to speak on monoclonal gammopathy of undetermined significance, MGUS, MUGUS, or MGUS, you can call it whatever you wish, and then I'll go on and talk about multiple myeloma. It's actually a combination of two separate presentations. I'm first going to speak about the prevalence of MGUS and to make the point that there is no such thing as de novo multiple myeloma. All result from an MGUS. A few words about the recognition of MGUS in medical practice and the duration of MGUS before it is recognized, and then I'll say a few words about the progression or possible progression of that entity. In the literature, by and large, it is said that about 1% of patients in a normal population above the age of 50 years have a monoclonal gammopathy of undetermined significance. We decided to do a population-based study in Minnesota, and as you can see, Minnesota is a state in the central part of the United States and on the very northern border with Canada. Olmsted County, Rochester, my home base, is here in the southeastern part of the state. We defined MGUS as a situation in which the M protein, M spike, is less than 3 grams per deciliter. The bone marrow contains fewer than 10% plasma cells, and there is no evidence of other B-cell disorders, and most importantly, no evidence of end organ damage. Olmsted County, when we started the study, had 28,038 persons who were above the age of 50 years, and we were able to obtain the serum samples from 77% of that population. We found that 3.2% of those persons 50 years of age or greater had an MGUS, and the prevalence increased from the 50s up through the 80s. In fact, those persons above the age of 70 years, 5% had an MGUS. This is simply the prevalence shown here, the males in red on the top, females in green on the bottom. We concluded from this study that the prevalence was almost constant throughout the duration of the study, suggesting that those patients who are ill with other diseases have no greater incidence of MGUS than those who do not. The prevalence was 4 times higher in persons greater than 80 years of age compared to those in their 50s. The prevalence was 2-fold higher than that reported in the literature of persons above the age of 50 years, and almost twice that previously reported in persons 70 years of age or greater. And we concluded that MGUS was the most common pre-malignant disorder in the general population above the age of 50 years. Now, we had the opportunity of looking at a serum collection from the National Institutes of Health called the PCLO study, which included over 77,000 people who had serum samples collected every year or two for up to 15 years. Now, during this long-term follow-up, 71 of these patients developed multiple myeloma out of the 77,000. And we found that a monoclonal protein was present in 100% of this population 2 years before the diagnosis of multiple myeloma was made. And in fact, 95% of people had an MGUS 5 years before the diagnosis of myeloma, and 82% of those patients who had developed myeloma had a monoclonal protein present for more than 8 years before the diagnosis. So this shows us that all patients with multiple myeloma have a preceding MGUS, and that there is no such entity as non-MGUS multiple myeloma. I won't get into the light chain MGUS today, but it also exists. Now, this was our conclusion, and in our practice at the Mayo Clinic, what percent of the patients we see have actually had their MGUS previously recognized during regular clinical practice? And I must confess that I was very surprised to learn that only 21% of patients age 70 who had an MGUS actually had it recognized with general practice, and it points out that unless one is looking for it on a regular epidemiologic basis, one doesn't see it. The prevalence in those persons, in those persons 50 years of age, only 8% of those patients had a recognized MGUS when it was present. Those persons ages 80 to 90, about a third of them had had an MGUS recognized at the time. Now, how long has MGUS been present when it is recognized? Most of us think that when the laboratory reports it today, that it happened yesterday. But I don't have the time to give you the background in mathematics, but my colleague Terry Thurno from our Department of Biostatistics has calculated that an MGUS recognized today in a 70-year-old person, that person had the MGUS present for 28 years before the recognition at age 70. So again, it's been around for a long time. And to summarize this part, only 22% of patients with MGUS seen at the Mayo Clinic had been previously recognized with routine clinical practice. 28% of patients who have an MGUS at age 70 have had it for more than 20 years. And the median duration of MGUS prior to its recognition is 11 years, not 11 days or yesterday. I'm going to skip a couple of slides here and go on and say a few words about why or what is the importance of recognizing a monoclonal gammopathy of undetermined significance. I collected 241 patients who had been seen at the Mayo Clinic between 1956 and 1970 who did not have any evidence of multiple myeloma, macroglobulinemia, amyloidosis, or lymphoma, and then have followed those patients and have divided these patients into 4 groups. The first are patients who are still living and have had no substantial increase in the M protein, accounting for only 6% of the total. 10% of the patients had an increase in the M protein of 3 grams or more, but did not develop symptomatic multiple myeloma requiring therapy. As you might imagine, over half of these patients died of unrelated disease, cerebrovascular, cardiovascular, non-plasma cell tumor, and the like. And most interesting were the 64 patients, 27% of the total, who did develop multiple myeloma or a related disorder. There are 2 points I want to make on this slide. First, 2/3 of the patients who progressed developed multiple myeloma, the others being Waldenstrom's macroglobulinemia, AL amyloidosis, or lymphoproliferative disorders, mainly lymphoma. And the second point I want to make is that the median duration of time from the recognition of the monoclonal gammapathy to its progression was 10 years. In short, when one follows a patient with MGUS for 10 years, your job is only half done. I might also point out that 10 of these patients did not develop their progression for over 20 years. This slide shows the progression: 17% at 10 years, 34% at 20 years, 39% at 25 years, about 1.5% per year. And we concluded that all patients with an MGUS needed to be followed indefinitely. Now, not everyone believed this, and we weren't so sure ourselves. So we looked at patients with MGUS in the 11 counties in southeastern Minnesota, 1,384 patients. The median age was 72 years, and these patients were followed for a total of 11,000 years, a median of 15 years, and at the time of this report, 70% of the patients had died, indicating a rather mature follow-up. And here is what we found. 75 of the 115 patients who progressed developed multiple myeloma, about 2/3, the same as before. And when we looked and compared this with SEER data from the state of Iowa, which is just next door to us, one would have expected 3 cases of multiple myeloma in that population. Instead, we had 75 for a relative risk of 25. Lymphoma, relative risk of 2.4, AL amyloidosis, 8-fold increased risk, Waldenstrom's a 46 increased risk, no increase in CLL, overall a 7.3 relative risk of progression overall. This shows the progression, and in the orange line at 10 years it was 10%, at 20 years it was 21%, at 25 years 26% per year. Now I might point out that the M protein was smaller in these patients because the diagnosis was made with the electrophoresis in the early part of the study with cellulose acetate, and then later with agarose gel, whereas in the 241 patients diagnosed in the 50s and early 60s, those patients were diagnosed with Whitman paper, electrophoresis, and that is not as sensitive. This is a very important slide for the clinician and takes into account death from all causes. And as you can see in the yellow line is the progression to death from a plasma cell disorder, myeloma or the like. In the dotted line is the death from cardiovascular disease, cerebrovascular disease, or non-plasma cell tumors. And when you stop and think for a moment that day 0 here is age 72 years, and if you take a 72-year-old person and follow that person for 25 years, there are lots of things other than multiple myeloma that can occur to that patient. Risk factors for progression. The major one is the size of the M protein in the serum. And for those patients who have a 25 gram per liter spike at the time of diagnosis, the risk of progression to multiple myeloma at 20 years is 48.8%. But those patients who have a very small M spike, 5 grams or less, still have a risk of progression over this 20-year period of 13%. The second risk factor is the type of M protein, and I'm not going to show you the evidence for that, but patients with an IgG, with an IgA or an IgM monoclonal protein will progress more likely than will a patient with an IgG monoclonal protein. The third risk factor is the free light chain level. And my colleague Vincent Rajkumar looked at 1,148 of these 1,384 patients who still had serum in our freezers, and found that 33% of these patients had an elevation of the free light chain ratio. And then categorized the patients into risk groups. The lowest risk group were patients who had an M spike less than 15 grams per liter and who had an IgG type of monoclonal protein and a normal free light chain ratio. These patients had a 2% risk of progression at 20 years, 5% absolute risk. And for those patients who had all 3 risk factors, that is an M spike greater than 15 grams per liter, and IgA or IgG, and an abnormal free light chain ratio, the risk of progression was 58% at 20 years, or taking into the competing other causes of risk was 27%. And we concluded from this study that patients with MGUS were more likely to die of unrelated disease than to progress, that multiple myeloma accounted for 65% of those who progressed. The risk of progression was 1% per year, and the risk of progression depended upon the size of the M protein, the type of the M protein, and the free light chain ratio. And again, our conclusion was the same, that all of these patients must be followed forever. Now, I want to spend just a couple of minutes telling you about smoldering multiple myeloma, which is really the big brother of monoclonal gammapathy of undetermined significance. These are patients who have a serum M spike 30 grams or greater, and or a bone marrow that contains 10% or more plasma cells, but no end organ damage. One can remember end organ damage by the word crab, C, hypercalcemia, R for renal disease, A for anemia, or lytic bone lesions for the B. We identified and followed 276 patients with smoldering multiple myeloma seen at the Mayo Clinic from 1970 to 1994. We stopped at that point to give us 10 plus years of follow-up, and we divided the patients into three groups. Those who had an M spike 30 grams or greater and a bone marrow with 10% or more plasma cells accounted for 38% of the total, or an M protein less than 30 grams per deciliter, but a bone marrow 10% or more plasma cells, half of the patients. And the third group, accounting for only 10%, were the patients who had an M spike 30 grams or greater, but a bone marrow that contained less than 10% plasma cells. During the follow-up, 162 of the 276 patients progressed, the vast majority to multiple myeloma, the smaller number to AL amyloidosis, and the relative risk of progression to multiple myeloma compared to a normal population was over 500-fold. The risk of progression to AL amyloid was increased 50-fold. When we looked at these three same groups, the median time to progression of the patient who had an M spike of greater than 30 grams and bone marrow plasma cells 10% or greater, a median progression of 2 years, and 87% of the patients in this cohort had progressed at the time of last follow-up. In contrast, the median time of progression of the patients who had an M spike greater than 30 grams per liter, but a bone marrow that contained fewer than 10% plasma cells, median progression was 19 years. Overall, in these 276 patients, the median time to progression was 5 years. Looking at it as an optimist, half of the patients had not progressed after 5 years of follow-up. This is the curve of progression. 51% progressed at 5 years, and that would be 10% per year for the first 5 years. The next 5 years, it was about 3% per year, and then after 10 years, the risk fell to 1 to 2% per year. So the longer your patient with smoldering myeloma survives, the more optimistic you and the patient can become. And this is the progression curve for the three groups that I just described and compared to MGUS by itself. And as you can see, it's a gradual progression based upon these criteria. My colleague Angela Dispenseri did the free light chain ratio on these patients. And in short, those patients who had a very abnormal ratio, the relative risk of progression was about twice that compared to those who did not have that increase in the free light chain ratio. And this slide simply shows the group of patients. And in the highest risk patients, 76% of patients who had all of these risk factors progressed at 5 years. And ultimately, our goal is to identify those patients who are at very high risk and then consider prospective randomized studies to see if one can prevent the development of multiple myeloma or related disorders. But one must again be very careful because you want to do no harm, and all of the agents that we have today for the treatment of multiple myeloma do have potential adverse effects. And this is something for all of us to keep in mind. The famous neuroanatomist Ramon Cajal made the statement that it is important to realize that everything discovered in a practical field is almost nothing in comparison to what remains to be discovered. And that is something that we must keep in mind. And sure, we think we've made a lot of advances and a lot of progress, but still we know very, very little about the cause and actually the effective treatment, or I should say cure, of multiple myeloma. So we have a ways to go. And if you could put up the other set of slides, if you will. I want to go on and talk about a bit about multiple myeloma here. My disclosures, which are mainly disease monitoring or independent review committees on various ongoing studies. First of all, multiple myeloma is a relatively rare disease. Only 1% of all malignancies are multiple myeloma, and only a little more than 10% of all the hematologic malignancies are multiple myeloma. The incidence in the US among Caucasians is 4 per 100,000, 40 per million, and that would end up with about 1,600 new cases of multiple myeloma in Poland each year. In the African American population, the incidence of multiple myeloma is twice as high as in Caucasians, and I might also add that the incidence of monoclonal gammapathy of undetermined significance is twice as high in the African Americans as it is in Caucasians. And we have had the opportunity of studying the serum of almost 1,000 men from Ghana in West Africa and find that the prevalence of MGUS in Ghana is the very same as it is among the African Americans in the United States. Multiple myeloma is defined as having 10% or more plasma cells in the bone marrow or histologic proof of a plasmacytoma, and an M protein in the serum, usually greater than 30 grams per liter, but not necessarily so, or monoclonal protein in the urine, that is kappa or lambda, the Bence-Jones protein, or lytic bone lesions. Most importantly, these patients do have end organ damage. And that consists, of course, of hypercalcemia or renal insufficiency or anemia or lytic bone lesions, all of which must be due to the plasma cell proliferative disorder and not to some unrelated cause. Smoldering multiple myeloma I've already addressed, and we can skip that. We feel that it is important to classify patients with multiple myeloma into two major groups. Patients with high-risk multiple myeloma constitutes about 25% of the total in our experience, and we define those patients on the basis of fluorescence in situ hybridization FISH, and those patients have a deletion of 17p or a translocation of 414 or 1416 or 1420. Or if they have deletion of chromosome 13 by conventional metaphase cytogenetics, or hypodiploidy with conventional cytogenetics, or a very elevated plasma cell labeling index. Those patients who have hyperdiploidy or a translocation 1114 or 614 have so-called standard risk myeloma. Then we utilize this in our approach to the patient, and for those patients who have, quote, standard risk multiple myeloma, who we deem as transplant eligible, and eligibility for autologous stem cell transplant varies from institution to institution. In Western Europe, most people use the age 65. In the US, most people use 70. However, chronologic age is not important. What is more important is physiologic age as well as other features. And these other features are quite variable, and one ultimately decides, or the patient decides. At least in the US, our patients are not as perhaps likely to listen to our advice as much as they might be here. And so sometimes the patient says, I do or I do not want an autologous stem cell transplant. If we're on the track to do an autologous stem cell transplant, we give 4 cycles of Revlimid or lenalidomide and so-called low-dose dexamethasone, that is dexamethasone in a dosage of 40 milligrams once weekly, or a bortezomib containing regimen. They have not been compared head-to-head, but in looking at the data, the results are comparable with the 2 regimens. After 3 to 4 months of treatment, we collect stem cells, and we collect enough stem cells for 2 transplants. Then one has the option of proceeding maybe you can attach that. Thank you. Of proceeding with the autologous stem cell transplant, or one can continue with the Revlimid dexamethasone, or and one can do an autologous stem cell transplant anytime along the line, and the overall survival is not significantly different. We prefer to do the autologous stem cell transplant initially because this allows the patient who has a successful transplant to remain without therapy. If the patient does not achieve a complete response or a very good partial response after the first transplant, we consider or suggest that the patient have a second autologous stem cell transplant, but many patients say that one's enough, and that's okay too. We then do not, in our practice, do not put the patient on a maintenance schedule, but follow that patient, and then when the disease recurs, to then treat the patient, or if the patient has remained in remission for 2, 3, 4 years, we will then do a second autologous stem cell transplant. The other option is to continue the Revdex or the bortezomib-containing regimen to maximum response, and then our usual practice is to stop and to wait and to see what happens. At this point in time, you have read in the literature that the time to progression is shorter or is longer if one places the patient on maintenance therapy after an autologous stem cell transplant. But that is true, but we don't know, in fact, I doubt if the overall survival is any different, whether the patient is on maintenance or whether the patient is treated with Revlimid or Velcade when the patient relapses. Now, the patient who falls into the high-risk category, that is 25% of the patients. We recommend 4 to 6 cycles of bortezomib, Velcade, and there have been a variety of regimens, and again, these are all phase 2 studies, and no one knows which, if any, are better than the other. We then will collect the stem cells on these patients because autologous stem cell transplant is still another treatment option. And then we generally would recommend maintenance therapy with the Revlimid dexamethasone in this group of patients. But again, one can stop therapy and wait until relapse occurs and then go ahead with therapy. Now, for those patients who are not eligible for an autologous stem cell transplant because of age, concomitant medical problems, or if for some other reason autologous transplant is not available, for the standard risk patient, today the best data is melphalan, prednisone, and thalidomide, but a recently completed but not yet published study from Western Europe using Revlimid and dexamethasone, I suspect that this is going to be equivalent or better perhaps even than the MPT, and certainly will not be associated with peripheral neuropathy. If the patient falls into the high-risk group, the 25% high risk, we recommend melphalan, prednisone, and bortezomib and treat to the point of maximum response. And then one can either observe or continue with, for example, Revlimid and dexamethasone. Again, no data favoring one approach or another. It's up to the individual. Now, that's an overall look at treatment. Let's look at a little more detail at some of the studies in patients. First of all, initial therapy for the patient who is transplant eligible. This is a study that was done by the Eastern Cooperative group chaired by my colleague, Dr. Raj Kumar, in which 470 patients with newly diagnosed untreated multiple myeloma were randomized to receive thalidomide in a dosage of 50 milligrams daily, and then, if tolerated, was increased to 200 milligrams daily. And in this study, the dexamethasone was given in the old standard fashion, days 1 to 4, 9 to 12, 17 to 20, or the patient was randomized to receive a placebo plus dexamethasone, same dose, same schedule. And as you can see, the complete response, partial response combination, 63% for the Thal-dex, 46% for the dexamethasone alone. Time to progression, 22 months for the Thal-dex, 6 months for dexamethasone. But in this particular study, the risk of deep venous thrombosis, thromboembolic phenomena, 12% versus 2%. This is also a ECOG study chaired by Dr. Raj Kumar, in which 445 patients with newly diagnosed multiple myeloma were randomized to receive lenalidomide, Revlimid, in a dose of 25 milligrams, days 1 to 21, plus dexamethasone in the standard dose, 40 milligrams, days 1 to 4, 9 to 12, 17 to 20. Or to receive lenalidomide, same dose, same schedule, plus dexamethasone, this time the dexamethasone given as a single dose, 40 milligrams at weekly intervals. And we see the 1-year survival of 88% for the RevDex, which is quite respectable, but 96% for the RevDex. And at 2 years, it was 88% survival for the Revlimid dexamethasone given weekly, compared to 78% for those patients who were receiving the larger dose of the dexamethasone. And this decrease in survival was mainly due to complications of steroids, particularly infections. In this study, the incidence of deep venous thrombosis, thromboembolic phenomena, 25% for the RevDex standard, 6% for the weekly dexamethasone. Incidence of infection, 14% versus 7%, favoring the weekly dex. And for that reason, we feel that dexamethasone should be given only at weekly intervals. And if you ask me if 40 milligrams is the correct dose, I don't know the answer. It's the only one we've needed. I am sure for many patients that 20 milligrams would be sufficient, but we don't know that. This is a study that my colleague, Dr. Lacey, reported at ASH 2 years ago of the early study that we did with lenalidomide as a single drug. We had 34 patients in this early phase 2 study, and after 4 cycles of therapy, the patients with a complete response were 6%, very good partial response, 32%, and were those patients who continued. The patient had the option in this small study of either proceeding, all patients had stem cells collected, but the patient had the option of deciding whether to continue with the lenalidomide or going ahead with the transplant. And actually, 2/3 of the patients said, oh, I'll continue with this oral medication, save the transplant for later. And so those patients who were continued on the lenalidomide, 24% of those patients achieved a complete response and a very good partial response in 43%. And so you can see that as the lenalidomide is continued, its effect upon the disease also continues. This is a study reported by Dr. Nowitzki from Cornell in New York, in which they used lenalidomide, same standard dose for 21 days each month, plus dexamethasone, 40 milligrams weekly. But here they added clarithromycin, that is Biaxin. And as you know, Biaxin has had a rather checkered career with multiple myeloma, initially reported to be effective for patients who are refractory to virtually everything, and then subsequent studies from several institutions reported that it was really of little or no benefit. But here, when combined with the lenalidomide and the dexamethasone, produced 90% partial response, and it appears that it is more effective than just the lenalidomide and the dexamethasone. Again, no prospective randomized studies, so we really can't say too much one way or the other. Bortezomib, or Velcade, is also an option for the patient with newly diagnosed myeloma. The study by Dr. Jagannath was reported first in 2006, and then just a few months ago reported a long-term follow-up. The response rate, CR or NCR, 19%, PR, 71%, total response, 90%, and the overall survival here at 4 years was 67%, which is very impressive. So we actually have 3 very good drugs that are effective: thalidomide, lenalidomide, and bortezomib for our newly diagnosed patient with multiple myeloma. Now, just a word about autologous stem cell transplant. This is a study from the UK in which 401 patients with newly diagnosed multiple myeloma were randomized to receive the group's favorite chemotherapy regimen, ABCM, adriamycin, BCNU, cyclophosphamide, and melphalan, or intensive therapy, that is an autologous stem cell transplant utilizing melphalan 200 milligrams per square meter. And as you can see, the complete response rate, 44% in the autologous transplanted patient versus 8% for the chemotherapy. The progression-free survival, 32 months versus 20 months, and the overall survival, 54 months, a year longer than the patients treated with chemotherapy, indicating that autologous stem cell transplant is a viable approach. The advantages of an autologous stem cell transplant is that the mortality is low, about 1%, and in our practice we start many of our patients, most of our patients, as outpatients, and we are able to complete the autologous stem cell transplant completely in almost half of patients without ever hospitalizing them. autologous stem cell transplant available for up to half of patients with multiple myeloma. But on the downside, the the reinfused stem cells are contaminated by tumor cells. And in fact, there have been several randomized studies looking at cell selection, and the removal of large numbers of identifiable myeloma cells from the hematopoietic stem cells does not alter the time to progression or the overall survival, indicating that the problem is that we are unable to destroy the tumor. And as you know, one has to tell the patient that this is not a curable procedure, and even though the response rate is very high, virtually all patients with autologous stem cell transplant will relapse anywhere from a few months to 5 years or longer, 10 years. I've seen patients with a single transplant who've gone 10 years. Now, if the patient has gone more than 2 years, then it's not a bad idea to offer another autologous stem cell to that patient, because that patient will again get a reasonably decent duration of response. This is a overall analysis of a number of autologous stem cell transplants, and by and large, the data for both overall survival and progression-free survival generally favors patients who have a high-dose chemotherapy, that is an autologous stem cell transplant. And this is the survival curve, which is essentially identical in patients who have an early autologous stem cell transplant, in our experience at the Mayo Clinic, compared to patients who have a delayed transplant, that is, the transplant is given later when the patient has relapsed. Overall survival is the same. As I mentioned earlier, we prefer that the early transplant be done because it gives the patient a period of time when they do not have to have any chemotherapy, and that's very good for the patient. No maintenance therapy is really free of side effects. Oops. Allogeneic transplant. What role does that play in multiple myeloma? Well, first of all, the reinfused stem cells would not include any tumor cells. But on the downside, over 90% of patients with multiple myeloma are ineligible for a conventional allogeneic transplant because of their age and the lack of a matched donor. The mortality is high. In the initial reports, it was about 40%, and today it's still in the 20-25% range. There is graft versus host disease, and some of these patients will still relapse years later with multiple myeloma. And in short, most people do not recommend a conventional allogeneic transplant for multiple myeloma, except under very extenuating circumstances. Now, another approach is the non-myeloablative, or the mini allogeneic transplant. Nicholas Kroger from Hamburg and Dr. Badros, when he was at the University of Arkansas, both reported a series of patients. Their transplant-related mortality, 18 and 20%. More recently, Dr. Maloney at the Hutchinson and Dr. Bruno from Italy reported a mortality of 4 and of 10%. And there is a very large study from the U.S., over 600 patients, comparing autologous transplant followed by a non-myeloablative transplant versus a autologous transplant only, and that data has not yet that study has not yet been reported, so we don't know. In my opinion, patients with non-myeloablative approaches have a lot of trouble with graft versus host disease. Many of these patients will relapse, and I think until the data is in, it's probably better not to do a non-myeloablative transplant on a patient with multiple myeloma unless it's done in a prospective randomized study. Now, what treatment do we have initially for that symptomatic patient who is not eligible for an autologous stem cell transplant for some reason or another? Well, for many years we had melphalan and prednisone, and one needs to adjust the melphalan dosage so that there is some cytopenia at mid-cycle, but nonetheless, only 50 to 60% of patients will have a response to melphalan and prednisone, and a complete response is very, very uncommon. And so, for decades, people developed various combinations of alkylating agents. Yours was better than mine was better than the next fellow, and we spent decades arguing back and forth which was best. Well, the Oxford myeloma trialists looked at the individual data from 4,930 patients from 20 different prospective randomized trials, and they lumped all types of combination chemotherapy together and compared that with patients who had been randomized to melphalan and prednisone only. And as you can see, the response rate with the combination, 60% versus 53% for melphalan and prednisone, a very, very respectable p-value, but there was no difference in overall survival, and furthermore, there were no subsets of patients who did better with intravenous chemotherapy than patients who were given the oral chemotherapy. And if I were giving you this talk 20 years ago, I would have said, absolutely, the patient who has aggressive, far advanced multiple myeloma should definitely be given intravenous chemotherapy. But in this meta-analysis, this could not be supported. So, after 4 decades of clinical research, we were back to where we were in the early 1960s. Kind of embarrassing. Then Dr. Palumbo from the Italian myeloma group reported a study of 255 untreated multiple myeloma patients who were deemed to be ineligible for an autologous stem cell transplant. And most of these patients were deemed ineligible because of their age, and they were randomized to receive melphalan, prednisone, thalidomide, or melphalan, prednisone, given in the same dose, same schedule, both for 6 months. And he reported a response rate of 76% with the MPT versus 48% for melphalan, prednisone. Complete response, 16% of the MPT, 2% of the melphalan, prednisone. 2-year event-free survival, 3-year survival superior in the MPT. However, with further follow-up, he has reported that there is no difference in overall survival in the patients who received MPT or melphalan prednisone. This study showed a much higher incidence of grade 3 to 4 adverse events, 48% patients with MPT versus 25% for melphalan prednisone, thromboembolic phenomena, 12% versus 2%, infection, 10% versus 2%, and as you would expect, only 8% peripheral neuropathy, none in the melphalan prednisone regimen. This is a study from the French, Dr. Facon, reporting on 447 patients who were randomized to receive MPT. Here the dose of thalidomide was given at 400 milligrams if tolerated and continued for a year, or to receive melphalan prednisone for the same dose, same schedule for a year, or VAD followed by 2 autologous stem cell transplants with melphalan just 100 milligrams per meter squared. And as you can see, progression-free survival, 28 months for the MPT, 18 melphalan prednisone, the 100 milligrams the same, and the overall survival, 52 months for the MPT, which is very respectable, 33 months for the melphalan prednisone, which is reasonable, and the VAD followed by the melphalan 100, intermediate survival at 38 months. Dr. Houlin of the French myeloma group reported on 229 patients, 75 years of age or older, and randomized them to melphalan prednisone thalidomide, and here he gave them just 100 milligrams daily, or to melphalan prednisone, same dose, same schedule, alone, and found or reported a progression-free survival of 24 months versus 19 months, and an overall survival of 45 months versus 27.7 months for the melphalan prednisone alone. Dr. Palumbo has reported in a phase 1-2 study has come to the conclusion that the maximum tolerated dose of melphalan in these persons 65 years of age or greater was 0.18 milligrams per kilo, and the lenalidomide 10 milligrams daily. And as I mentioned a little earlier, they have completed this large randomized study, but it has not yet been reported as a journal article. It was reported briefly at ASH last December, and the melphalan and lenalidomide was superior to the melphalan alone. This is an important study reported by Dr. San Miguel, an international study in which well over 600 patients were randomized to receive bortezomib or Velcade standard dose and schedule plus melphalan, 9 milligrams per meter squared, plus prednisone 60 milligrams, days 1 to 4, and then cycles 5 to 9. The bortezomib was given at weekly intervals, or the patient was randomized to receive melphalan, same dose, prednisone, same dose, same schedule as they received in the other regimen. And here is the report. 37% of the patients who received MPV had a complete response compared to 4% with melphalan prednisone alone. Partial response or better, 71% of the MPV compared to 35% melphalan prednisone. And the duration of response, again, longer with the MPV, median 19.9 months versus 13 months for the melphalan and prednisone. There was a price to pay, as you can see and would expect. Neutropenia, thrombocytopenia, anemia, GI symptoms, fatigue, asthenia, and so forth were higher in the VMP, but those were not really major problems. But the sensory motor peripheral neuropathy was a real problem, 13% having a grade 3. There was another 14% who had grade 2 peripheral neuropathy. And if you're the patient, grade 2 peripheral neuropathy is pretty significant as far as you are concerned. Now, let's go on and talk for just a few minutes, finally, about the treatment of relapsed and or refractory multiple myeloma. Unfortunately, the vast majority of patients with multiple myeloma who survive get to this state. For the past 25 years, we have had VAD, vincristine, adriamycin, and dexamethasone. And since vincristine and adriamycin were given by continuous infusion for 96 hours and thereby not easy to give, most physicians, or many physicians, gave dexamethasone alone, 40 milligrams daily, days 1 to 4, 9 to 12, and 17 to 20. But as you well know, this is a very large dose of corticosteroids and is associated with very, very significant effects, side effects, and in reality, one is unable to maintain this rate and schedule. And then in the last decade, we have had thalidomide, bortezomib, and lenalidomide. The first report was by Dr. Singhal when she was at the University of Arkansas, reported a 32% objective response in 84 patients with refractory or relapsed myeloma. Dr. Barlegi reported roughly the same, 169 patients. The French, 41%, but they included minor responses. And this has been the experience of most people. About a third of patients will have an objective response with thalidomide. Bortezomib, this is a study reported by Dr. Paul Richardson at the Dana-Farber, 193 patients. Whoops. Anyway, it was 193 patients, and the objective response was about 30%, and the duration of that response was about a year. He subsequently chaired an intergroup study of 669 patients with relapsed multiple myeloma, randomizing these patients to bortezomib standard dose, standard schedule, or to receive dexamethasone 40 milligrams on the standard schedule. Time to progression, 6 months of the bortezomib, 3.5 months with the dexamethasone, and the survival was also about 6 months longer in the patients randomized to bortezomib. This is a study reported by Dr. Orlowski, who tells me that he is not related to the Professor Orlowski, who I understand is considered to be the father of internal medicine in Poland. Is that correct? not related, but Dr. Robert Orlowski's father did did a significant amount of early work on bortezomib in the laboratory. In this particular study, Dr. Orlowski, the young Dr. Orlowski, reported on 646 patients randomized to receive bortezomib or bortezomib plus liposomal adriamycin, doxin, and reported a 3-month longer time to progression and actually a bit longer survival in those patients who received the 2 drugs. This is an important study, 009 and 010 from North America or Western Europe, and you may have participated in this study, in which 704 patients with relapsed refractory multiple myeloma were randomized to receive lenalidomide standard dose and schedule plus dexamethasone standard dose and schedule, or dexamethasone alone, same dose, same schedule. I've combined the 2 studies here for simplicity because the protocol was identical and the results were really the same. 60% of patients obtained a complete or partial response with the Revdex compared to 22% for the dexamethasone alone. Time to progression, almost a year with the Revdex compared to the dexamethasone alone, which had a time of 4.7 months. We're very interested in pomalidomide, which is a new analog of thalidomide and lenalidomide. This is a report that my colleague Martha Lacey gave at ASH a year ago. We've now had experience with more than 150 patients with pomalidomide. We reported in the initial study, and our subsequent studies are essentially the same. Very good partial response in 24% of patients. Partial response, 38%. In other words, in patients relapsed refractory myeloma, about 60% had an objective response. And I want to emphasize that about half the patients who were refractory to bortezomib and about 40% of patients who were refractory to Revlimid did respond to pomalidomide. It's an oral drug. It's quite well tolerated. There is some neutropenia, some thrombocytopenia, but all one needs to do is to reduce the dose of the pomalidomide a bit. And we're looking forward to seeing this drug. I think that this will be an important advance for the treatment of multiple myeloma. Now, have we made any progress? We do a lot of talking, and we talk about all of these good studies with all the good results. What have we done? As you recall, in those first 40 years of chemotherapy, we didn't do very much. Well, my colleague Shaji Kumar looked at our data at the Mayo Clinic at 2,981 patients that we saw from 1971 to 2006. And he looked at the survival of those patients who were diagnosed after 1996 and those patients who were diagnosed from 1971 to 1996. And as you can see, the median survival of those patients diagnosed after 1996 is 44.8 months, compared to 29.9 months for those patients diagnosed between 1971 and 2006. The reason for the improved survival here is the autologous stem cell transplant and the 3 novel agents. I must confess, and we have looked at survival of these patients prior to 1996, and you can almost cover one 10-year survival curve with the other over this 25-year period of time. Absolutely no progress. Dr. Kumar also looked at our patients, 387 patients with multiple myeloma who had an autologous stem cell transplant at the Mayo Clinic, and looked at those patients who had a transplant and then at the time of relapse were given one of the 3 novel agents. The survival after relapse following the autologous stem cell transplant was 30.9 months. For the 226 patients who had relapsed following an autologous stem cell transplant and who did not receive bortezomib or thalidomide or lenalidomide, the median survival of those patients was only 14.8 months, which I think is additional indirect evidence that these 3 new agents are very, very important. And on a closing note, there is good news ahead. There are a variety of agents that are undergoing phase 1, phase 2 studies. And just for example, there's a histone deacetylase inhibitor, vorinostat, or SAHA, that is in a phase 3 study now. Tenespamycin, that study has been abandoned because of difficulties in synthesizing the drug. There's a new proteasome inhibitor that can be given orally instead of IV, NPI-0052, that's in phase 2 studies. There's an FGFR3 inhibitor, P38 MAP kinase inhibitor. There is another drug, carfilzomib, which is a proteasome inhibitor that is entering phase 3 now. And so far in the phase 2 studies, these patients given carfilzomib have not had peripheral neuropathy. And then, as I mentioned earlier, pomalidomide, which also is very promising. And with that, I thank you for your attention, and I apologize for going relatively rapidly, but hopefully you obtained the gist of this. And if you have any questions, comments, disagreements, and so forth, I'd be more than happy to hear them. Thank you.